Thank you. I'm pleased to be here with you this afternoon, and what I'd like to do is sort of take you from the high level that we've been talking at and dive down into some of the nitty-gritty details for a moment and sort of introduce you to some of the ways that NCQA has incorporated issues of culture, language, access, and health literacy into our evaluation programs. And then I also want to show you a little bit about some of the results that we've seen from this work. Let's see if we can. So just for those of you who are not familiar with NCQA, we are a nonprofit organization that measures and evaluates healthcare quality. Our mission is to improve the quality of healthcare. We do it through a variety of measurement and evaluation programs. We're probably best known for our accreditation of healthcare plans and for our recognition of patient-centered medical homes. We have a number of programs underway at NCQA that are relevant to the discussion topics here. Probably the most critical are our accreditation programs for health plans and ACOs. The number for those two types of organizations is probably more closer to 1,200, and the rest of the 1,500 are bits and pieces of other kinds of programs. That also includes our Multicultural Healthcare Distinction Program, which is focused specifically on issues of cultural competence, language access, and healthcare disparities. We are stewards for the Healthcare Effectiveness Data and Information Set, which was referenced earlier today. This is HEDIS, and the numbers that you see here are the number of health plans reporting. We have about 1,100 submissions to HEDIS. Those include Medicare, Medicaid, and commercial submissions. They include both publicly reporting and non-publicly reporting organizations. That is, we have plans that report to us, and we can use their data as we develop benchmarks and aggregates, but we don't individually identify them. And then we have recognition programs for patient-centered medical homes and for specialty practices. You can see we have significant numbers involved in these. And our CLAS standards are integrated into all of these programs. So that's the big picture. You can see that, at least theoretically, there is a lot of opportunity here for focus on CLAS. I'll share with you some of what that looks like. In our health plan accreditation program, we have pulled in a number of standards from our Multicultural Healthcare Distinction Program. But needless to say, the healthcare accreditation program is a much broader focus and addresses a lot standards in a lot of other areas as well. And so I just wanted to give you sort of at a fairly high level, sort of a compare and contrast of how deep we can go into these issues. So on the health plan side, we have standards in many categories, obviously, therefore many fewer standards related specifically to CLAS. We do have health literacy addressed throughout those standards, but not actually specifically called out as health literacy. We have standards about a lot of different kinds of information that need to be provided to subscribers and members in understandable language is the way we've described that, and that's pervasive throughout the standards. The Multicultural Healthcare Distinction Program is a very specialized program that focuses specifically on class and disparities, and so that's what the standards really address predominantly, and we don't address health literacy at all in the context of that program. So both programs have a strategic focus. With health plan accreditation, the program description has to specify objectives for serving a culturally diverse membership. And then there are 8 other things that are listed as required components of the program description within health plan accreditation. Within the Multicultural Healthcare Distinction Program, there's that same objective for serving a culturally diverse membership, and then additional requirements that really go deeper into this. So a process to involve members of the diverse community, a list of measurable goals specifically for improving CLAS. So just to give a sense of how these, the different focuses play out. In terms of the cultural competence of the network, there is a comparable standard in both our health plan accreditation and our multicultural healthcare distinction program. That is that, the network has to be responsive to the cultural and linguistic needs of the membership, and that the organization has a way of measuring that and then making adjustments as necessary. The Multicultural Healthcare Distinction Program goes further again and actually requires collection and publication of information about the practitioner languages and language services. So it goes further in terms of not only making sure that the right languages are represented in the network, but that there's transparency to the membership and there's easy access to information that would allow people to choose providers who are language concordant. With respect to language services, again, we have just different levels of specificity here. One of the biggest differences from my way of thinking is that we've described the requirement in the Multicultural Healthcare Distinction Program to provide competent interpreter or bilingual services. At the time these were written, the certification programs were only just beginning, so we couldn't specifically require certification. It would have been premature at the time. But certainly we intended through the language of the standard to allow for certification to satisfy that requirement. The standard also requires support to practitioners in providing language services, understanding that for health plans and systems, they may not be delivering language services at the point of care, but they have an obligation to help their providers deliver language services effectively. With respect to quality improvement, our health plan accreditation program requires a variety of quality improvement efforts, but we're not prescriptive about what health plans focus their improvement efforts on. With the Multicultural Healthcare Distinction Program, we require a focus on measurement and improvement of language, cultural competence, and then the effectiveness of the interventions to improve both of those. We have data collection standards, and again, health plan accreditation requires reporting of selected HEDIS measures. It's actually a very long list of HEDIS measures, and these are primarily measures related to the effectiveness of care. They do not specifically include measures related to CLAS. On the Multicultural Healthcare Distinction Program, we require collection of data on race and ethnicity and on language needs, and then reporting those measures. So HEDIS includes 2 measures of diversity. It's the languages spoken and the race ethnicity of the membership. But for health plans going through accreditation, the reporting of those measures is voluntary. So these are the 2 measures. The intent of these measures in HEDIS is to get health plans to actually capture, record, and count what are the languages spoken by their members and what's the racial and ethnic makeup of their population. Presumably this would enable them then to actually measure and report on disparities and do a variety of studies that, that involve stratification. We've had less than exciting results on these measures. Thank you. Just to show you, we have very low levels of information reported by health plans about race, ethnicity, and languages of their members. Much better measurement of these things from Medicare plan side, much lower on the commercial side. And it's a continuing challenge to capture data. And this, you'll see, contrasts with the experience that we've had on the provider side. Our patient-centered medical home recognition program also includes standards related to cultural and linguistic appropriateness. And the standards are written here. So they have to assess the diversity of the population, assess the language needs, provide interpretation or bilingual services, and provide printed materials in the languages of the population. They also need to use an EHR or an electronic system to record information in structured data fields and then to assess health literacy. So those are the standards that apply both in the patient-centered medical home and also in the specialty practice recognition program. We've run some numbers on this, and you can see the performance is really very good in terms of doing these things. Now, this is a small number that's reflected here on our most recent iteration of the standards that were published in 2014. We did a similar analysis of many more practices, 1,100 or something practices, based on the 2011 standards, and had slightly lower performance, but still quite high. It was in the 80s and 90% for all of these, with the exception of health literacy, which wasn't included in that set of standards. So the key takeaway here is that at least at the provider practice level, they're doing a good job of capturing information about race, ethnicity, language needs. They're doing not quite such a good job on assessing health literacy, but half of them are still doing it, or more than half. So it's happening at the provider level. It really helps a lot that the requirement to measure these things is part of the Meaningful Use incentive program. And that's actually something that I wanted to sort of elevate for discussion. So clearly, there are measures and standards related to cultural competence, language access, health literacy. These standards are available. They're embedded in very popular, long-standing, but voluntary programs. But what we have found is that purchaser and regulatory incentives make a huge difference in the uptake of these programs. So on the provider side, the alignment with meaningful use makes a huge difference. There's a synergy that happens when there are incentives for doing things that are part of otherwise larger and potentially dilutable set of standards. We understand that Covered California is considering making the Multicultural Healthcare Distinction program a requirement for its health plans. Right now, I don't know if you remember from one of the earlier slide, we have about 1,200 health plans that are covered by our health plan accreditation program. We have 16 organizations that have gone through that are currently holding our multicultural healthcare distinction. So the uptake of this, very specialized but voluntary program is really limited, and in order for there to be better use and application of these standards, more leverage is needed. We've recently done a study for the Center for Medicare and Medicaid Services Office of Minority Health involving literature review, environmental scan, where you know, it was really clear that there is delivery system reform fatigue out there. You know, so there are so many reforms underway. There's so much effort to transform the healthcare system. Many of these efforts have incentives attached to them. There's pay for performance and all variety of value-based purchasing. In order to get organizations to focus on issues of culture, language access, literacy, there have to be incentives that at least equal what they're being incented to do. Otherwise, they're going to follow the money, and that's really what we've heard from them. So there's real opportunity, I think, from the regulatory and purchaser side to channel those efforts and that attention to these issues, but it's not going to happen without advocacy. And as we heard earlier in the discussion, I don't know about the anger thing, but the passion and the advocacy is what's going to make the purchasers and regulators bring these issues into their incentive and value-based purchasing programs. So thanks. Look forward to questions later.